I want to acknowledge with humbleness and gratitude that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And each of you around the province and potentially outside of the province are on similar lands. I think on days like today where you can see the beautiful sunshine and the mountains and the ocean, as Susan was just talking, and appreciating tides and the impact that that has on wildlife and everything else. I think it's great for us to pause and acknowledge, and I certainly am thankful for being able to be here. Next slide. So it's really with great privilege and pleasure that I get to introduce Dr. Susan Ott. Dr. Ott graduated from Stanford University. I did medical school at the University of Washington and residency at the University of California at Davis, and a nephrology fellowship at the University of Washington. She, by her own admission, never left the University of Washington and eventually became a professor in the Department of Medicine, an adjunct professor in the Department of Orthopedics and Radiology. She really has a diverse interest and knowledge within the context of metabolic bone disease, and did research in aluminum bone disease, bone histomorphometry, and osteodystrophy, as well as osteoporosis and other diseases. She's been involved extensively in clinical trials of osteoporosis treatments, the effects of contraceptives, and long-term effects of bisphosphonates. She was a member of the KDIGO Committee on CKD MBD and gave the Jack Coburn lecture at the ASN in 2016. So it's really with great privilege and thanks to our endocrinology colleagues at UBC that Dr. Ott is going to speak to us on bone disease in CKD patients and how to target the treatment. So Susan, I'll pass it over to you, and thank you very much again for agreeing to be here, and hopefully next time it'll be in person.
Yes, thanks very much. And so let's see if this works. Share screen.
Yep.
There we go.
Perfect.
Okay, so today I'm talking about bone disease in CKD patients. And I don't have any conflicts of interest. And the topics I'm going to talk about today are a graphical review of bone physiology and the actions of the osteoporosis medicines, and also the physiology in the renal osteodystrophy patients. And then we'll talk about clinical studies in ordinary osteoporosis and in CKD. And I'm going to end up with a few concerns about vascular calcifications. So to start out, the bones are living structures. Unlike the leg of a table, which can't repair itself, the bone can repair itself. And if you look a little closer inside, you'll see that it's composed of a lot of different cells. And the main cells that we're going to be looking at include the osteoblasts that form bone, the osteoclasts that dissolve bone, the osteocytes that remain inside the bone, as shown in this slide. So bone formation and resorption always go in the same sequence. And your bone is constantly repairing itself. Whenever there's a little crack or damage, you're going to dissolve it away and fill it in with new bone. And that's what our first animation is going to show. So there's the crack. Now your osteoclasts dissolve it, and then the osteoblasts fill it in. It always goes in that order, which is important when you're treating osteoporosis. So now we have a new packet of fresh bone. The coloring of the bone in all of these animations is a reflection of how dense they are, because brand new bone doesn't have as much mineral, but older bone is darker as it gets mineralized. Okay, next. Oops. Now we're going to show, if we step back a little bit and look at about as much bone as you see on one microscope slide. So that's a couple of millimeters. You have these, what we call BMUs, all over, and they're all asynchronous, repairing and forming bone. And so we're gonna show you about 3 years of bone turnover speeded up. And what I want to convey is the bone is alive, it's active. This is happening inside of all of our bones right now. And normally, the structure stays the same. You're just replacing it. And you're going to replace the trabecular bone about every 5 years. Oops. Okay, now what's going to happen is, what happens with menopause is that your osteoclasts are deeper, dig deeper. And so you're going to have more resorption, and you're going to try to catch up with more formation. So you have a higher turnover, but you're going to lose some of the structure. So let's watch that. So within a few years, you've got these perforations. And this is the beginning of the bone loss that causes osteoporosis. And you can also get some micro cracks. And these have actually been demonstrated on very accurate micro MRI studies that can happen in normal people, normal women after menopause in just 2 or 3 years. Okay, now what happens if we treat with SERMs? We're going to give some estrogen or SERMs, and it just slows it down. So these changes are subtle. And I might add that these changes are actually a graphic representation of our studies. So the surfaces are actually what we've measured in mini biopsies. And so what we see is really the important thing is what you didn't see. It's like the dog barking at night. What you didn't see is the perforations. So by giving these mild anti-resorptive drugs, you're just slowing the turnover down to what it was before menopause, and you're no longer perforating the bones. And that's how estrogens and SERMs act. Okay, bisphosphonates. We're going to have some turnover, and after 6 months, you'll see little diamonds, which represent the bisphosphonates that are going to come to attach to the resorption area. And they just freeze the bone. And so let's see what happens. Okay. Here come the drugs. So when we measure these surfaces, normal bone, about 6 to 8% of the surface is forming bone. And after bisphosphonates, it goes way down to about 0.5%. And so then the cracks that develop are not going to be repaired, and they can accumulate. And the bone becomes denser because the mineralization comes in and you don't turn it over. So we'll be talking about that a little bit more later. Now we're going to, oops, sorry, keep doing this. Now we're going to treat with bisphosphonates. We're going to treat with denosumab. And in 6 months, you're going to get an injection, and you'll get an injection every 6 months for a couple of years. And then you're going to skip, stop taking it and watch what happens. So this goes a little bit fast. You might notice there's no formation, but now we stop and you rapidly lose it and start getting perforations right away. Okay. Now we're going to switch over to a different kind of drug, which is teriparatide. And I'm actually showing you one real slide of a photomicrograph of the way we actually measure these is to look at the tetracycline labels, which are shown here. When you give somebody tetracycline, it deposits wherever you're forming bone. And if you give 2 labels, you can measure how fast you're forming new bone. And this would be a representative section from somebody who'd been treated with teriparatide versus somebody treated with alendronate. So again, we'll have 6 months of turnover, normal turnover, and then we'll start the teriparatide treatment. And this slide doesn't go so long because this is as long as the patients had been taking it before they got their biopsies. You might also notice that the bone is not as mineralized because it's got a lot of brand new fresh bone. So the density of this new bone is actually low. So you actually have more bone than you can tell by using techniques such as a density study to show how much there is. And finally, we're going to show what happens when you treat with romosozumab. And this goes very fast, but you're going to both increase the formation and decrease the resorption of bone at the same time. So after 6 months, you're going to start this treatment and see what happens for the next year. And after about 9 months, you start having some turnover again. But you can see you've actually gained bone. There's a lot more bone there. And again, it's not very densely mineralized yet. Okay. So now I'm just going to talk about the difference between ordinary osteoporosis and CKD. So somehow my titles got mixed up. This column is the CKD column, and this is the ordinary osteoporosis. And they're really different diseases. In CKD, we have increased PTH and alkaline phosphatase, which are normal in osteoporosis. You have bone density that's only weakly related to the fractures, whereas without CKD, the bone density predicts fractures strongly. The bone loss in CKD is mostly in the cortical bone, whereas it's in all kinds of bone with osteoporosis. And the bone turnover is often either very high or very low, whereas with osteoporosis, it tends to be generally normal, or it'll be slightly high or slightly low. With CKD, there's an association with vascular calcifications. And in osteoporosis, there's also actually some weak associations with vascular calcifications. And finally, the CKD patients have a whole host of abnormalities in biochemical measurements, including their calcium phosphate, FGF23. You can see them here, but BMP clotho, vitamin D, iron, sclerostin, activin, and cytokines. There's just a lot of abnormalities which are normal in ordinary osteoporosis. Put a slide up here showing the bone density in CKD patients. These are CKD 4 and 5 patients. And the Z-score is how far they are from average. And what this shows is that if you measure the wrist and the hip, which are cortical bone sites, you tend to be about a 0.5 to 1 standard deviation lower than you would expect for the age. But if you look at the spine, the bone density is normal, often even higher than you would expect. Now, you don't see that with ordinary osteoporosis. These numbers tend to be more concordant, and the spine is often the one that's the lowest. So this again gets back to showing how complicated CKD is, and I could spend the next 2 hours going through this, but the point of this slide is that there's a lot of factors that are going awry in chronic kidney disease. Here's some of the ones you're really familiar with: the high phosphate, the high FGF23, the low vitamin D. But we also have accumulations of toxins. We have problems with your signaling pathways, malnutrition, low IGF. And these factors give you different effects on the bone, which is why we get such a spectrum of disease. And the ones on this side are going to predominantly increase bone resorption and then secondarily increase bone formation rates. On the other hand, these factors are going to decrease bone formation predominantly, and some of them also decrease bone resorption. But we're going to have low turnover. So you can't often tell in an individual patient which way things are going to go. And so this is what they would look like on these same kind of slides, just to show the difference between high turnover and low turnover. So we'll start out with what happens in high turnover bone disease. And that pink stuff represents fibrosis. You look at all the formation, it's just turning over rapidly. The bone is not very strong because it's been formed so quickly that the bone is woven. And so you actually have decreased the cortex, increased the trabecular bone, and you've got a lot of bone, but it's not very strong bone. And a lot of times this is caused by hyperthyroid. Okay. Now here, oops, I keep doing this. Now here is osteomalacia. And that's when you form osteoid, but you can't mineralize it. So you go. So you can just keep forming bone, and pretty soon you have a lot of osteoid that doesn't have any mineral, and this is a soft, weak bone. And when we look at it under the microscope, what we see is a lot of red staining, which represents unmineralized osteoid. And finally, we have adynamic bone disease, where not much is happening. Sometimes there's no formation at all, but more often there's just a little tiny bit. And the bone is actually more mineralized, so it's denser, but not necessarily stronger. And in patients with CKD, the types of renal osteodystrophy have been shifting over the years. And we used to see a lot more osteomalacia and what was then called adynamic and mixed disease. But in the new millennium, we're seeing a lot more, we've changed the names a little bit, but low turnover, which used to be called adynamic, and high turnover, because it's not always caused by PTH. And the incidence of osteomalacia has actually gone down. And I titled this talk, Target the Treatment, because too often people just want to treat CKD as if it's all one thing. And you're looking for a drug that's one size fits all without even attempting to match the physiology of the bone to the mechanism of how the drugs work. And I'm going to postulate that that's the way we should be doing it. We need a lot more studies, but that's part of what this talk is about. What I'm hoping eventually we're going to be starting to do is choose the drug that would match the physiology of our patients. So first of all, osteomalacia, which is very rare, but gives me a moment to just mention vitamin D. And it, of course, if you have low vitamin D, that's one of the reasons for osteomalacia. And the dose of vitamin D that's recommended is between 600 and 800 units a day. Despite widespread recommendations of high doses, they've never been shown to help. either in CKD patients or in osteoporosis patients. And the blood level should be between 20 and 50 nanograms. And I don't know whether I can't remember, does Canada use nanomoles anyway? It's 50 to 125 nanomoles. The second thing about osteomalacia is to avoid aluminum. And these days, osteomalacia from aluminum is pretty rare, although when I first started, it was a lot more common. And nowadays, we'll still see the occasional patient who's getting too much aluminum somehow, or if there's some kind of accident with the dialysis, it still has been able to cause osteomalacia. Okay, now I'm going to talk about high turnover. And so we'll talk about bisphosphonates. And I'm going to be going through the drugs that we use now. And each time we'll talk about what happens in ordinary osteoporosis, and then followed by what we know about what happens in patients with kidney disease. So this is just the structure of bisphosphonates. They're analogs of pyrophosphates, so that lets them get into the bone. And in ordinary osteoporosis, there are large randomized trials that include about 35,000 subjects. And they've shown that the second generation bisphosphonates reduce fractures during the first 3 or 4 years of treatment, often by more than half. They work by blocking bone resorption, and that prevents the deterioration of the bone architecture. But you do pay a price because you're also blocking bone formation. And I'm showing this slide because I keep hearing over and over from people telling me that bisphosphonates don't cause adynamic bone disease, or nobody's shown that bisphosphonates really lower bone turnover. It's just a marker of the success of the pharmaceutical company's advertisement that people think that. So these are data slides from a lot of studies. Each one of these dots is a single study in normal people, and these are the standard deviation. And so these are normal children. They have high mineralizing surface, which is the surface measured by tetracycline forming new bone. These are normal adult women who are young. These are ones that are mixed ages. Here's the ones that are postmenopausal. These green dots are osteoporosis. And this yellow line shows more or less the average definition of a dynamic bone, about 1 standard deviation lower than we would expect in a normal young person. And these studies are people who have been treated with bisphosphonates, and except for this one small study, they're all well below that line. And these are the clinical trials of pre and post bisphosphonates. This is about an 80 to 90% reduction in the surface that's forming bone, and some of them go down very low. And as opposed to some of the other drugs we use, here by the way is teriparatide, where it goes way up, and romo's not on here, but it also goes way up. So you do cause adynamic bone disease, even in patients who don't have kidney disease. There's actually only one study I'm aware of where they actually looked in people with CKD, and indeed their turnover went way down. They couldn't see tetracycline in the patients after they took alendronate. Now, what difference does that make? Well, the difference that makes is that you get more cracks, and that changes the strength of the bone. And the crack density is shown by this study of people who were mostly had osteoporosis. They'd been treated with bisphosphonates from 0 to 17 years, and you can see that there's a steady increase in the number of cracks, and that corresponds to an eventual decrease in the strength of the bone. So during the first few years, the increase of cracks isn't enough to make much difference, and the fact that you've preserved the overall architecture is still important. And so you're definitely getting a benefit during those first few years, but it turns and starts getting worse, especially these are people who keep staying on the drug. And what consequence does that have? oh, here's just a picture of what they look like. When you stain them, these little micro cracks, micro damage will start to accumulate. And this is what we're worried about. And we see this atypical femur fractures that start out with a painful area in the thigh and the femur, often a reaction, and then with very minimal trauma, the bone is brittle and it just snaps. This is not the kind of fracture that you get with trauma. And these atypical femur fractures do increase with the duration of bisphosphonate use. This is one of the studies that I did with Rick Dell. And you can see that these kind of fractures are exceedingly rare in people who don't take bisphosphonates, and they start to go up, especially after 8 or 9 years in patients who've been taking bisphosphonate for a long time. Another side effect that may be related to the low turnover is jaw osteonecrosis, as shown here, where after a tooth is extracted, the bone is exposed and doesn't heal for more than 2 months. And this can get infected and lead to a lot of complications that are quite scary. And that is called jaw osteonecrosis. But the risk is really pretty low. Because it's a little hard to really define it, the studies aren't clear, but it's 0.001 to 0.01% with the usual dose. However, in patients with cancer who are getting very high doses, and some of them get 10 times what we give, you can see this problem in up to 3% of the cases. I would say that this scares patients more than it should. And I'm always reassuring them that, you know, look, your chance is 1 in 100,000. And so we don't let that worry us from starting the drug, but it should make us worry about keeping people on it for more than 5 years. Okay, now what about CKD stage 3? Well, in all of the major clinical trials of osteoporosis drugs, there are some subjects who had what I'm calling age-related CKD, grade 3. And they were, a lot of times the criteria for entering the study was like a creatinine lower than 1. But in an older woman who has low muscle mass, that's going to give you CKD3. And so they've done post hoc analysis. And so for every study, I have a post hoc analysis in early stages of CKD. But there's a real caution, is that the studies excluded sick patients, and they had to have normal PTH, alkaline phosphatase, and calcium. So these patients who had what we call CKD MBD, or when you start getting into the problems with later phases of CKD, they would have been excluded from all of these studies. So we're just looking at the, you know, the mild grade 3s. So this would be the one in, the best one was with residronate. And we see 3 groups here. So this group would be the ones with normal GFR. These were 30 to 50 mild, and these were less than 30. But when you recalculate them with MDRD equations, it was actually 42. But the point is that the difference between placebo and residronate was there. It was actually even a little bit more different in the chronic kidney patients than it was in the patients who had normal renal function. So if you have the early phases, you can use these drugs as you would in osteoporosis. Now, there's very few studies of bisphosphonates in patients with 4 to 5 grade CKD. And this is the largest one, which only had 51 patients. And when you consider the osteoporosis studies often have 5,000 and 6,000 patients, these really seem very small. And it didn't even really help that much. So at the spine, the bone density started out high. If you remember that the CKD patients have higher spine than average, and that was seen in this study. The 0 means normal. So they started out normal. And they did see that the alendronate improved the bone on the spine a little bit. And it did not, and of course the placebo didn't change. So there was an effect. However, at the femoral neck, that's where the problem was. And at the femoral neck, where the T-scores were considerably lower, the average down here at 1.6, 1.2, sorry, there was no difference. And so the bisphosphonates did not improve the bone density in the sites that were the problem in the CKD patients. The study also was looking at vascular calcification, and fortunately it did not get any, didn't get any worse. There was no difference in the progression. So to sum up bisphosphonates, there are inadequate studies in CKD 4 to 5 patients. And the data from patients with early CKD is not reliably extrapolated to later stages. And bisphosphonates do increase the PTH. They markedly reduce bone formation rates. And in osteoporotic patients, prolonged use increases the risk of atypical femur fractures. And the studies are in progress about what happens to ordinary fractures. Depending on how you look at it, those perhaps are also getting worse after prolonged use. And we're still a little uncertain on the long-term vascular effects. Okay, denosumab. I'm calling this from the frying pan into the fire in terms of bone turnover. Denosumab inhibits the bone formation even more than the bisphosphonates. And in bone biopsy studies, 80% of the patients had no tetracycline at all. And the others had just very small amounts. The denosumab is not cleared by the kidney, but that does not mean it's effective. I hear all the time that we can give denosumab to the kidney patients because it's not cleared by the kidney. And I say, well, that's not an indication for treatment. So what do we know? Not as much as we would like. But in ordinary osteoporosis, it increases the bone density. It reduces the clinical fractures. So that's true. It stops bone formation and completely stops bone resorption. There already are some cases of atypical fractures in jaw osteonecrosis, and the drug hasn't been used in enough people for a long duration to get the instance of this to see whether or not it's greater than with the bisphosphonates. But the thing that I'm the most worried about is that there's this very rapid, profound rebound loss after the denosumab wears off. So if you skip a dose, you lose the bone really rapidly. And that's shown in some of the earliest studies. This was the first trial of denosumab, first large trial. The red line started out at year 1 to year 3, and the blue line was the placebo group during the first 3 years. And then at year 3, the ones on the blue line also got denosumab. So by year 10, the red people here had been on it for 10 years, the blue had been on it 7 years, and then they stopped the study. And within 6 months, they showed a steep decline in the spine and even steeper here, so that they went down, here's the baseline, they went down lower than the baseline within 6 months of stopping the drug. And this was associated in some people with fractures. And so there's more and more reports now of multiple vertebral compression fractures. These happen within 7 to 20 months after the last dose of denosumab. And this was one of the patients that we saw in our clinic. Fortunately, somebody else had prescribed the denosumab and neglected to keep giving it. And here you can just see fracture after fracture. So this is devastating, and we don't really know quite what to do about this yet. There's lots of seminars about what to do, how to stop denosumab, and I think that we don't really know yet. But the second strongest anti-resorbing medicine we have is IV's alendronate. And that doesn't even really prevent the bone loss after denosumab. Here's one study. They'd been on denosumab and they gave zoledronate, and it probably did attenuate it. So they probably would have gone down to here without it, but still, to see a 5% bone loss after zoledronate shows how strong this resorption is. Now, that's in ordinary in ordinary osteoporosis. In CKD, again, just like the other studies, in the mild cases, it appears to work. These are chronic kidney patients in grade 1, 2, and 3, but these are the normal ones. And the vertebral fracture rates are significantly lower. It's kind of interesting, in this particular study, the ones with CKD actually had lower fracture rates. I think that was just a chance, but the point is that they all responded. The non-vertebral fracture rates didn't really respond that much in grade 3. And there weren't enough grade 4s to say anything. We also know that in CKD, denosumab lowers the calcium. And after a treatment in one study, 6 of 8 patients and 2 of 5 patients with CKD4 developed severe hypocalcemia with muscle cramp, seizures, tetany, laryngospasm, and cardiac arrhythmias. And these people need to be in the intensive unit getting calcium drips. So this can be a really serious problem. You can see that the parathyroid responds as you would expect by going up. So my summary about denosumab is that uncontrolled studies report increased BMD with denosumab in CKD 4 to 5 patients. But hypocalcemia is common and can be severe. Few studies show giving calcitriol to prevent hypocalcemia can result in serious vascular calcifications. And in osteoporosis, they can develop atypical femur fractures and jaw osteonecrosis, and we don't really know how often that happens in CKD. And after stopping, there's rapid rebound bone loss that may result in multiple vertebral compression fractures. My personal take on denosumab is that that last thing is so important that we stopped using it in our clinic. Okay, raloxifene is another medicine that works like estrogen. And I'm just showing you one of the primary reasons that we use raloxifene is to treat breast cancer. And in one study, this would be the women on placebo and the ones on raloxifene. Their rate of breast cancer went from 4.2 to 1.4. But it also prevents fractures in the spine. And I'm just jumping to the CKD patients now. In the post hoc analysis of the main raloxifene study, according to glomerular filtration rate, these are the normal women, these are the ones with CKD. You could see that you still saw a nice reduction in the fractures. Now, this drug is not quite strong enough to prevent non-vertebral fractures. And other drugs in this category actually do prevent non-vertebral fractures, but they are not available. It's been studied in dialysis patients, and the studies are small, but there's several. And the results have shown that the bone density in the spine has a significant increase, whereas the hip is not really changing. So it does help with spine bone density and with some parts of osteoporosis, even in patients with CKD. And in these studies, there weren't any side effects. So study just showing that same study that the markers of bone turnover go down about 40% with raloxifene. So a summary about raloxifene is that it acts like estrogen on the bone and can be used in postmenopausal women. In women without CKD, it reduces breast cancer and vertebral fracture. And the studies in CKD are not large enough to be sure about that. There's an increased risk of thrombophlebitis. It's the same as giving estrogen. It's about twice the risk of a normal woman. And in ordinary osteoporosis, there is no increase in the number of strokes. There was a study in women who had serious coronary artery disease, and they had the same number of strokes as the placebo group, but the higher percentage were fatal strokes. So the thrombophlebitis is something to consider. But overall, this is a generally safe drug and sometimes can be used in any grade of CKD. Okay, so now I'm just going to summarize all together. The CKD patients with high bone turnover, most cases are caused by high PTH. And so it makes more sense to treat the PTH in those cases. And theoretically, you could have high turnover patients who don't have hyperparathyroidism causing it, and that those could benefit from anti-resorbate agents. But there really haven't been any clinical studies that have tried to do that. They haven't really tried targeting the patients with high turnover that's not necessarily related to parathyroid hormone. And I will point out that there was a study of cinacalcet. I'm sure you guys are all familiar with this study. And this was a post hoc analysis of fracture rates according to age. And if you remember, everybody in this study, I think we're about 3,000 people in the entire study, they all took, they all had a parathyroid hormone that was greater than 300 to get in. And then the cinacalcet group in here had lower rate of fractures at all sites, and looking at non-hip and hip, they had lower rates of fracture compared to the placebo group. So in your older patients who have PTH greater than 300 and have osteoporosis, I would seriously consider giving cinacalcet. Now we're going to turn over all together, looking at the low turnover cases. And so we're going to talk about drugs that increase turnover. So those are what we call anabolic drugs. And the first one is teriparatide, which has always seemed like a paradox. Why in the world would we give PTH or even think about giving something like PTH to somebody with kidney disease when we've spent our whole career trying to lower the PTH? But there might be some patients in whom it would work. So in ordinary osteoporosis, I'll point out, well, PTH is teriparatide is PTH 1 to 34. In laboratory rats, it causes cancer, osteosarcoma, but that has not been seen in primates or humans. It has an anabolic effect that diminishes with time after about a year. And it requires daily injection, and it must be followed by an anti-resorptive medicine. Abaloparatide is a little bit newer, but it works the same way as PTH-related protein 1 to 34, and so it activates the same receptor, and it has the same mechanism of action as PTH. There's a lot of contraindications, so you wouldn't want to give it to somebody who'd had a history of malignancy, radiation, or Paget's disease, hepatic disease, or recently discontinued denosumab. That's because when you stop denosumab, you have rapid bone resorption, and when you start teriparatide, that enhances rapid bone resorption. Of course, you wouldn't give it in hyperparathyroidism, abnormal protein electrophoresis, if you have hypercalcemia or hypercalciuria or high vitamin D or high uric acid, because it can precipitate gout. And of course, you have to have you can't give it to somebody who's really non-compliant. They have to give themselves injections about the same time every day. If you don't do that, it can actually increase bone loss if you get sporadic increases of PTH. Okay, adverse effects now we're talking ordinary osteoporosis still. You can have hypercalcemia, you can have hypercalciuria and kidney stones, you can get gout. These are the important ones. Nausea, dizziness, and bone aches happen, but in our experience, those usually go away after a few weeks of getting used to the drug. when you discontinue it, you do get a loss. It's not that rapid loss of denosumab, but it does go down over a year. And the loss is shown here in one study where, where the bone goes up, and then when you stop, it comes down. And in this case, if you gave raloxifene, you would preserve it. And at the hip, there was a little lag, but it started going down. It was preserved with raloxifene. So when we give this drug, we follow it up usually with raloxifene or a bisphosphonate. Okay, so in early CKD, again, as a post hoc analysis of the osteoporosis trial, there were a few people who had a grade 3, and the vertebral fracture rates in this study were higher in the placebo group who had CKD, and they showed a really nice response to the teriparatide. And these were the normal kidney patients showed a response. The non-vertebral rates, interestingly, they didn't have any in either group in the patients with CKD. So it does look like this is, especially for the vertebral fractures, very effective if you have early CKD and meet all of those criteria of normal PTH, calcium, alk phos that were necessary to get into the study. Okay, when we look at CKD MBD or grades 4 to 5, the studies just become very small. This was an interesting study done in Greek patients where they biopsied all their patients who had low bone density. They did a bone biopsy and they divided them up into groups according to whether they had low turnover, a high turnover, or normal. And so 8 of these patients had low turnover, and their PTH was on the low side, especially for a dialysis patient. And the study was during the baseline, they just followed the people for a year. And you could see that their bone density, it was going down at the spine and the hip. And then they started the treatment and looked at what happened the next year. And at the hip, it didn't change all that much, but the spine did show an improvement. So it's showing that in low turnover people, you are getting some improvement in the bone density. And with 8 patients, you can't tell about fracture rates. And here's another study, again, 7 patients, but they'd had a history of parathyroidectomy. They had low PTH, but they showed a pretty consistent increase in the spine and a mild increase in the hip in a lot of these patients. So the summary about using teriparatide in grades 4 to 5 CKD, the studies are very small, but they do have positive results on the bone density. There's a pretty good rationale physiologically for giving PTH intermittently to patients who have low serum PTH and adynamic bone disease. Bone loss does occur following discontinuation, and so there needs to be a plan for a second choice. But there really is very little data. So we have there's a lot of opinions by people who like to study renal osteodystrophy that we should be doing more work on using these teriparatide medications in the adynamic bone disease. And finally, I'm going to talk about romosozumab because that's the newest kid on the block. And romosozumab is a monoclonal antibody against sclerostin. Sclerostin inhibits the Wnt signaling pathway, which is necessary for osteoblast function. This is what happens if you don't have any sclerostin lifelong. You get a disease which is scleriostosis, a very thick skull. It's a bad disease because the nerves are compressed. But interesting, their relatives have normal life expectancy, normal function of everything, but they don't fracture their bones, even with lots of very interesting traumas. They have T-scores in the +6 range. there's no increase in heart disease or cancer in people who don't have sclerostin. Here's the study in ordinary osteoporosis, looking at the bone density, which is higher with Romo than with anything previously, especially at the spine, but also at the hip. And this one also, if you stop, you start to lose it. So it goes up and it comes down. And if you start again, it'll go up again. So currently what people do is you give it for a year, after which time it's lost its effectiveness. You have a refractoriness. And you can treat with alendronate and keep the bone density up. But what really matters is not what happens to the bone density, but what happens to the fracture rates. And here's the alendronate. These women and men had, no, I'm sorry, these were the women. They had osteoporosis. And so it was not felt ethical to treat them with a placebo. So we're comparing alendronate from years 0 to 4, shown in the gray line, and this is the fracture rate. Whereas the Romo group got treatment for a year and then switched to alendronate, and for the next 3 years, they still had a lower fracture rate. So this is currently the best combination that we have for severe osteoporosis. Side effects, there was a increased risk of myocardial infarction in one study, but not in the largest study. The FDA did an analysis, and they thought that they didn't see that there was a significant difference, but they nevertheless advised against giving it to people with a recent MI. So otherwise, there aren't any serious side effects. Grade 3 CKD, this was just published. When they looked at that study I was showing you, if you gave Romo to grades, here's CKD 1, 2, and 3, even in grade 3, you were seeing that same really nice decrease in risk of vertebral fractures. And here, this was a second study where you were seeing a decrease again. So the grade 3s were working just as well as the grade 1s. In rats who have chronic kidney disease, the bone density, volume, and mechanical properties improve, but only when the PTH was low. A single dose in CKD shows markers of bone formation go up as well. So here's the CKD5 in pink compared to the healthy. And you can see that you had almost as much improvement in the markers of bone formation here, P1NP and BSAP. And you had reduction in the markers of resorption that, again, was almost as good in the kidney patients as in the patients with normal renal function. And there's been one study that just was published just about 5 months ago. 96 dialysis patients from Japan with low bone density were treated for 1 year. The baseline PTH was 152. The bone density increased 15% at the spine, 7% at the hip. They did not report any increase in cardiovascular effects. It was not worse than 55 untreated patients. And this was not randomized. They had some asymptomatic hypocalcemia. And so this is a very interesting study. And I think it means that we're going to be needing to do more studies of using this medication in CKD. So I have to end up, I think I have just a couple minutes left, just to say that patients with CKD have a high fracture risk and they die of heart failure. And so we have to consider vascular calcifications. And here's just one of my pictures showing that this patient, there's more calcium in the aorta than in the vertebra. Here, look at this. And so we have to consider this. And I love this quote from John Wesley: "Dust thou art, and then to dust thou shalt return. In extreme old age, the arteries themselves, the grand instrument of the circulation, by continual apposition of earth, become hard, as it were bony, till, having lost the power of contracting themselves, they can no longer propel the blood, even through the largest channels, in consequence of which death naturally ensues. So here, we've known about this for centuries. Now, the Wnt signaling pathway increases bone formation and resorption. That makes us happy. But it increases renal fibrosis, and it increases arterial wall calcification. So we need to worry about that. And I'm going to end with this slide, which is very, very complicated. But sclerostin is one of a whole host of factors that influence this. So the main question that we really need to find out, is this very important, or is it just one of a whole lot of factors? And so that knocking this one out, all these other factors will take its place. And until we get a little bit better hold of this, I'm not going to be able to say, go out and give Romo to everybody. But I'm hoping that this is only going to be minor, and that these other factors, especially this one and this one, will come in and take its place. Maybe Clotho will help. Okay, so that's the end. And if I stop sharing, I can do the Q&A.
Thanks, Susan. That was incredibly comprehensive. There are quite a number of questions, and I guess we don't have a lot of minutes. If people don't mind staying for a few minutes after, I think that it's just such an important problem, and as you alluded to, quite complicated in our population. So there are some questions in terms of the value of doing DEXA in our patients and the value of measuring vitamin D levels in kidney patients versus simply replacing in a fixed dose kind of way. So some of those recommendations. And then I'm just kind of trying to paraphrase and bucket all of the different questions, but in people who are who we inherit on denosumab, how would you prevent bone loss and fracture after you stop it, whether we should give IV zolodronec or the I can't even say it, romosozumab. So maybe that's a lot of questions, but all in the theme of best measurements, supplemental things, preventative.
Yeah, I can see him now, now that I stopped sharing my slides. So, well, I'll start off with the chat question. I guess there was one chat question. In patients who are on denosumab, what would be the best option for preventing bone loss and fractures? Okay, so this is actually the subject of a lot of ongoing seminars and things. And so we've got to do something right now. So I'll tell you what I do. If somebody comes in who's been on denosumab, I will wait 7.5 months after their last dose and give them IV zoledronate. I give them 5 milligrams of zoledronate IV. And if they have CKD, then I'll still give them zoledronate, but I will lower the dose and give it over an hour, kind of trickle it in, and I'll give like either 2 or 3 milligrams. And then I start following the urine NTX, which this is another thing about denosumab. It can go down and you might think this is great. And then another, month or two later, it pops back up again. So you have to keep following, and if it pops back up, you have to give another dose of zoledronate. Okay. Would I try Romo? I've seen a report that it didn't work and somebody still got fractures. And I saw another report that it seemed to attenuate it. So at this point, no, I'm not trying Romo. It does block bone resorption, but not as strongly as zoledronate does. So for now, we're using the IV zoledronate. And there's a new cell that's been described. They're called, if you have a minute, they're really fascinating. When you have osteoclasts, and normally when they finish resorbing bone, it takes a few weeks and they undergo apoptosis. However, if you block RANK ligand, they don't undergo apoptosis. Instead, they divide up into a lot of little cells that have never been described before until they've been seen in people who've taken denosumab. And these little cells are not pre-osteoclasts. They have the same machinery as osteoclasts. And so they've named them osteomorphs. And
Oh,
they have one nucleus. But if rank comes back, if rank ligand comes back and they've got rank receptors, they will almost instantly fuse into a giant osteoclast that is ready to go. So you got this team of cells floating in your circulation, and they seem to accumulate with denosumab use. And as soon as the denosumab wears off, they will then attack your bone with a vengeance. So if you have that in mind, you're going to see that you got to stop them with the strongest drug you can.
yeah,
Okay.
or never start it, I suppose, in our patients.
Yeah, like I say, or don't start it in the first place.
Yeah, so there's a lot of questions about levels and the PTH targets and those sorts of things, which you and I both know has been the focus of a bazillion different conversations. Some pragmatic questions about bisphosphonates in calciphylaxis patients. What is your thought on that?
I'm not sure, actually.
Okay.
So
that's a good answer.
Yeah, I'm not really sure about calciphylaxis. I think almost I would probably try some other things before bisphosphonates, but that's something that we still don't understand. In terms
so maybe let's go back. Like, I was always taught that if one does like a bone density in kidney patients, it's not all that helpful. Do you agree with that? Because I think it doesn't give you the information that you think it does, or it might erroneously lead you to do something. Like, is that fair? Or because I do think that a lot of these different treatments being given perhaps erroneously are based on erroneous diagnoses.
I actually am going to agree. And this has been very controversial. Does it even predict fractures? And I think there's sort of two ways that if your bone density is low, it's hard to imagine that that's good for you. So yes, if you have a really low bone density urine problem, the main reason that I don't think it's all that necessary to get the DEXA is that we don't really have any reliable treatments to give. So then it becomes, well, what are you going to do differently if it's low? You might know that they're at a higher risk, but you're gonna still encourage all the things that we know about, like getting exercise, getting a good diet. You're still going to try to keep the PTH under control. And until we have a more firm recommendation about medications, then that are going to use to treat it, then knowing that your patient is a high risk isn't going to help too much. And then the other problem is that if it comes back normal or high, it can mask. Still, the quality of the bone can be terrible. And so you can still have a high fracture risk. So you might be falsely reassuring the patients. And so until we have, and actually, if you really look at the studies comparing bone density to fracture rates in dialysis patients, there's a lot of disagreement as to whether it even predicts fracture rates. And a lot of the studies don't show that it even helps.
Yeah,
so
I think that's,
I don't, it's hard to really say, well, don't do it at all. I mean, it's completely safe, it gives you some information, but we don't really quite know what to do with it. If we had some really good treatments, then we would have to figure out a little bit more when we could use them.
No, thank you. That's actually, I think, in this era of, being mindful of what one generates in terms of not just costs, but waste and various other things for tests that are that equivocal and perhaps non-helpful in our patients. Perhaps we're better to concentrate on what we do know and what treatments do work and what's harmful, as opposed to a test that doesn't tell us specifically anything more than we knew before. I think that there's been lots of comments in the chat about what a lovely talk you've given, a really dynamic and interesting re-educating of all of us, I believe, with respect to the dynamic nature of bone and the specific challenges in people with kidney disease. Susan, it's really great to refresh all of our thoughts. I think that there's going to be so many unanswered questions, and we hope that we can look to you for expert guidance, and that with our endocrinology colleagues here in BC, we can develop some safe and logical strategies of how best to work people up, what to make of the numbers, and then what to do that's good for it. So really, thank you so much for a great talk.
Well, thanks for inviting me.
Yeah, yeah, great. Thanks, everybody, and thanks for your attention.